it's my pleasure to introduce our recent work about the problem of hypoperfusion despite recanalization. And this is the result of a systematic review and meta-analysis of a randomized clinical trial of intra-arterial thrombolysis as an adjunctive to successful recanalization. And as we all know that acute ischemic stroke can be effectively treated by intravascular thrombectomy, but unfortunately, there's less than 50% of patients can achieve the excellent functional outcome, and the mismatch between the high rate of recanalization and the relatively low excellent functional recovery can be attributable to lots of aspects, and which has been discussed in lots of review and a lot of conference. And a critical challenge is the incomplete reperfusion, which is persisting in over 30% of patients despite a successful large vessel recanalization. And we now understand that there's two distinct mechanisms of the incomplete reperfusion after the successful large vessel recanalization. And firstly, is the territorial hypoperfusion from distal emboli. And the second is the no reflow. Maybe the no reflow phenomena is more popular and in the field of ischemic stroke, but the territorial hypoperfusion was reported by more and more works in this field. And recently, several randomized clinical trials has been conducted to investigate this question, but their result has been inconsistent. Importantly, the trial adopted different inclusion criteria. Some enrolled patients achieving eTICI 2B or better, while other trials enrolled patients with 2C or 3. And these scores are not equivalent in terms of functional outcome and incomplete reperfusion rate. And therefore, we conducted a systematic review and meta-analysis of recent published random clinical trials, which aims to quantify the overall efficacy of the efficacy and safety of intra-arterial thrombolysis, and investigate some outcomes modification by eTICI grade, which may be helpful for the future clinical trial design. And in this systematic review, we included 6 clinical trials, and they were the choice trial, the POST-UK, POST-TNK, Angio-TNK, PRO, and DATE. And all the trial employed different thrombolytic agents, and 2 used the intra-arterial TPA, and 3 used the TNK at a varying dose, and 1 used the urokinase. And critically, for our subgroup analysis, 4 trials enrolled patients achieving eTICI 2B reperfusion or better, and while 2 trials enrolled patients with eTICI 2C or 3. And our primary finding of this meta-analysis is that the intra-arterial thrombolysis was significantly associated with the high rate of excellent outcome at 90 days with a risk ratio of 1.24. Importantly, there is a very low heterogeneity across these 6 studies. And we also performed a subgroup analysis by the reperfusion grade. And we can see that in patients who achieved eTICI 2B reperfusion or higher, and these part of patients showed significant benefits from the intra-arterial thrombolysis. And in contrast, in patients with eTICI 2C or 3, reperfusion, and showed that only a trend towards benefits with a risk ratio of 1.22, which didn't reach the statistically significance. And while we test for the subgroup interaction, that was not significant, and this pattern strongly suggested that patients with incomplete reperfusion are the ones who benefit most from adjunctive intra-arterial thrombolysis. Are those patients that who achieved eTICI of 2B or higher, and especially in the subgroup of patients with eTICI 2B. And this also make pathophysiological sense if we have better initial tissue level reperfusion, and there is less thrombolytic burden remaining for the thrombolytic agent to address. And in addition, we also performed ordinal analysis of the MRS distribution that they did showed a favorable shift with the intra-arterial thrombolysis. And but when we performed a secondary outcome to evaluate whether the intra-arterial thrombolysis can benefit patients that who achieved the functional independence, but there was no significant difference. And regarding the safety outcomes, and we found that the intra-arterial thrombolysis is not associated with the symptomatic intracranial hemorrhage rate, and even in patients who received intra-arterial thrombolysis treatments prior to the intravascular thrombectomy. And above all, intra-arterial, in this meta-analysis, we found that intra-arterial thrombolysis was associated with a high rate of excellent outcome at 90 days, and the subgroup analysis suggested that only the subgroup of patients who that with eTICI 2B significantly benefits from the intra-arterial thrombolysis, whereas no significant difference was detected among patients with eTICI 2C or 3, and with, however, a trend towards benefits for patients treated with the intra-arterial thrombolysis. And while our analysis showed no significant increase in hemorrhagic complication or mortality, and the limited number of the safety events necessary caution interpretation. And as we all know that the incomplete reperfusion is a very common phenomenon, especially in patients who achieved the large vessel recanalization after thrombectomy. And understanding the mechanism of this phenomenon may help to guide our future management in this phenomenon. And based on our comprehensive review written that supplement to that has been accepted by the Annals of Neurology, and incomplete reperfusion results from multiple mechanisms. And these include the distal emboli and the residual microthrombosis, and which are directly targetable by thrombolytic agents. However, other mechanisms include the microvascular dysfunction, the peristaltic construction, and the progressive microvascular failure that actually continue and can worsen the first 24 hours after the recanalization. And the intra-arterial thrombolysis therapy primarily targets on a mechanical obstruction, but has limited efficacy for microvascular dysfunction. from this meta-analysis, what does this mean for the clinical practice? And I think maybe for the following prospects. Yeah, firstly, our finding suggests that the intra-arterial thrombolysis should be strongly considered for patients who achieved eTICI-to-B perfusion after thrombectomy, and patients that who achieved the eTICI-to-C or 3 may still have a distal emboli not visible on conventional angiograph. And future trial should incorporate perfusion imaging to better identify the patients that who can benefit from the intra-arterial thrombolysis therapy after thrombectomy. So, and these are the findings from the meta-analysis of the problem of the meta-analysis of the problem of hypoperfusion despite recanalization.